We have a what we call a connected care system with our Cleveland Clinic health system. So we have Cleveland Clinic practitioners embedded in these skilled facilities. And then we have that, and then we have an outer ring of facilities that work with our with all of our hospitals that don't necessarily have a Cleveland Clinic practitioner embedded, but they are part of our ACOs. So they have agreed to work within our guidelines and work with us in our transitions of care.
So just a little historical perspective. We created our post-acute network, preferred partnership, as a partnership. It's not there's no financial kind of arrangement among us about 4 years ago. And it consists of home health agencies, SNFs, hospice, LTACs, and then we do have our own acute care rehab facility. First, I think the first strategy was really having scorecards where we can manage those, all of those partnerships. But I would say the main strategy that we employed that has worked, we hold hands with them and we don't let go. And what I mean by that is we don't just rely on our monthly meetings. We do meet with each of our preferred partners monthly, but we actually have weekly calls with all of our preferred networks. Each of my managers is responsible for a relationship with a particular post-acute partner. So, for example, I have a manager that has one home health agency and may be responsible for a relationship with one of the SNFs. Each week, they talk about any complex patients, anyone that is high risk for readmissions. They ensure that we have insight into what's happening in the home or in the post-acute facility, and we talk about it proactively, because what we were finding is waiting a month for your monthly meeting just was not enough, and by the time you get to that patient, the patient would have readmitted there, and it doesn't allow for proactive problem solving. So we really partner with them. For our SNFs in particular, we have two major networks. Chicago's very big and spread out very geographically. And as an academic medical center, we have patients that come from really all over the country, but also in neighboring states like Indiana, Wisconsin as well. So with the SNFs, we had to have partners that had a wide geographic range. But with that said, there's probably about 10 SNFs where the preponderance of our patients go, and we have providers that are embedded in those facilities. And so one of the strategies that we employed is really doing that warm handoff from our facility to our partners that are embedded in those SNF facilities. And we track that to make sure that we have 100% compliance, and we can really start some of that advanced planning prior to the patient ever leaving the facility. Each of the partners are required to, as part of their agreement, to network with each other. So if a patient discharges to a SNF, but then needs home care after the SNF, then they use our preferred partnership. So they stay within our network, and we track that as well. We actually have navigational services that are embedded on each of our inpatient units as well that really ensure that our patients have follow-up appointments within a certain period of time, depending on their chronic condition, and we track that. So we're very data-driven, and I think that's really important in terms of accountability and to really find areas of opportunity that we can work on. And so those strategies really has helped us really maintain a strong relationship with our facilities, but really problem solve as partners to really impact some of those outcomes measures.
I would say at Duke we have what they've developed, the HOPE Collaborative. It's a collection of skilled nursing facilities in the area that have agreed to partner with Duke in terms of improving that transitions of care. And that's more for the elderly population, to focus on them. And they've used the EPIC system. We use MedLink. So when we transition patients out, we can digitally send that information to the facilities. Those have monthly meetings, and they have quarterly conferences just to talk about best practices. That has helped to build a relationship. So when we're discharging our more complicated patients that may not be elderly, we've already got the relationship with those facilities. So we've been able to work with them on some more complicated people and moving them through the system. We also partner with Durham Homeless Transitions Care. They will work with our homeless population that can't return to the streets or the shelters. So we also make sure we're there monthly meetings with them to kind of discuss those patients that we're transitioning out. And really it is hand-holding. It's making sure that you're not leaving them in the lurch when you discharge these patients that are really complicated.
Thanks. So one of the key phrases I just picked up on there is moving or transitioning really complex, tough patients. So to segue into our next question, what have you done to really leverage your post-acute care network to really tackle those complex, tricky patient transitions?
One of the things we have done, we have leveraged the clinical expertise of our physicians and providers, and partner with the different facilities that are in our network. And so by doing that, we have embedded some of our hospitalists in the facilities as medical directors. We have we have embedded our mid-levels as well in the facilities to have the coverage for Monday through Friday coverage for those facilities who are needing some type of provider intervention during that time. And we have seen that we have decreased the amount of patients coming back to the ED for those simple things, for instance, like an EKG. We have increased the clinical expertise in the facilities by doing the stat EKGs within the facility, improving the clinical competencies of the nursing staff at the facilities as well. One other thing that we're beginning to do is actually have our cardiovascular medicine nurses and mid-levels provide some type of training to those facilities, where we're thinking about sending our advanced CHF patients there. And so we have started that process with training of the staff and making sure they are ACLS, making sure they actually have the tools they need to be able to do some of those advanced things. We also begin to partner with our home health agencies by making sure we have some type of transition guide for them at the facilities, and also for at the agencies, and also to make sure that they are embedded in our hospitals by early intervening in the hospitalization stay. And so that's by having the home health agencies come in, speak to the patients so they can have a smooth transition from the hospital to the home health agencies. So that's what we started.
We also have, we have our own home care agency. We have partnerships with LTAC and with acute rehab. And kind of the same, same type of program. We train their teams to handle our LVAD and our transplant patients. There would be no way that either LTAC or acute rehab could assume the care of those patients. So in Pryor, they used to just stay with us for a year, sometimes longer. So now, which wasn't beneficial to the patient. They weren't getting up, becoming more functional. So we took responsibility to train our partners in both the LTAC and the acute rehab to be current on caring for these patients. Depending on the type of transplant, we have two acute rehabs on either part of town. So, one group took one group of transplants, another group took another group. And also with our home care, we all know home care has become so technical, and really encouraging patients to go home, but at the same time, patients, we used to just push the sniff easy button. We no longer do that. We really encourage patients to go home, and like we've heard from so many great speakers, really beefing up the home care to manage those types of patients. So we also have our physicians. We have a physician at home program. They will go into the homes, or the PAs or nurse practitioners, and we have EMS teams that will go in and check on the patients. So it really has just evolved into this growing collaboration network.
Many of the same things that my two partners discussed up here with having embedded providers and things of that nature. For our home health, I think one of the areas of opportunity we were finding in particular is that patients were discharged, and if nurses are in the field and let's say they need updated orders and things of that nature, and then being a large academic medical center, they wouldn't know who to reach back to, or they would try to get to the primary care physician, but the patient hasn't even made it to the primary care physician, so they were lost. So one of the strategies that we employed is our hospitalists still follow the patients for a week post-discharge. So, and the home health agencies know who to reach back to if they need updated orders and things of that nature. And that really helped, because as we looked at our data, we found that most of our readmissions were happening 3 days post-discharge. And so that was an opportunity that we wanted to shore up. Again, trying to let the data drive where we needed to embed some different processes. For our SNF relationships, it's very similar. We have patients who are out for LVAS, or patients who are transplant, who may not transition to LTAC, but maybe are more SNF level of care, particularly with some of the different rules around LTAC. So what we found is, every SNF isn't equal. And so what we really have tried to do is create kind of subspecialties in some of our preferred partners. So for example, we have partners that are really specialized in behavioral health, so we try to move those patients there. There are some SNFs that have dialysis on site, some do not. So for certain patients, we try to get them into those facilities. We have created care paths with certain SNFs around our neurosciences. We have a huge stroke program, and have worked with the nursing staff there to ensure the nurses have the competencies to care for these patients. And we also want to give our physicians the confidence that their patients will be cared for at that level of care. So we've partnered with the School of Nursing to provide education and try to I wouldn't say steer, because of course patients all have choice, but we try to encourage our patients to select those particular facilities. So we've kind of created niches within certain our SNFs that we really can ensure the nurses have the competency, have the staffing to care for some of our more specialized populations that need that level of care. And that's proven to be very successful, particularly with our SNF population that are not quite LTAC, but really are a highly complex patients.
And when you mentioned that, I have 2 programs that we've kind of worked with. One, we started the COMET program this past year, and that was really to address our patients with opioid use dependency. And so that program will initiate Suboxone treatment for them inpatient when they come in-house. And so where we were getting stuck were the patients that would need the 6 weeks of IV antibiotics. So we reached out to our SNF, the one that usually works with our more complicated patients, and they really partnered with us. We worked with them, and we reached out to our LME to identify some mental health providers in the community that would do Suboxone. So now we can move these patients to that particular SNF. They do their IV antibiotics there, while they also attend an intensive outpatient program to get their Suboxone, as well as getting connected with like a peer support specialist that can connect them with resources, housing, things like that. So when they're leaving the SNF, they're in treatment and they've got resources to hopefully have a more successful discharge plan. And then the other one is the Durham Homeless Transitions Program. We partner with them for our homeless patients that come in as traumas or have an infection. Like I said, they can't return to the street or the shelter. They will provide the case management. There's a nurse case manager and a social worker on their team to really help connect them with primary care, also with social services. And then we also work with a gentleman that's got multiple houses throughout the Durham city called Just a Clean House. We can house these patients for 1-2 months, however long, to help them stay in a stable house while they're working with this homeless transitions program. So those are the 2 examples.
Thank you. So we have about 20 minutes left, so I'll ask one more question and then I'll turn it back to you. So something I heard yesterday and then heard again today that really stuck with me is that technology does not on its own equal innovation, which I very much believe is true. However, technology and tools can be supremely helpful. So our next question is, what tools and technology do your organizations use to really improve communication and share data across your partners and continuum and bolster care coordination?
So one of the things that we just started actually this week was actually, we call it our WellStar link. And that's actually an Epic link that we utilize for referral management to our post-acute providers. And with that, we provide them the clinical documentation and also the financial documentation for them to make a decision both ways prior to selecting them or prior to a patient actually being accepted from that facility. And so one of the things, once a patient is selected from their preference or their choice, the facilities or the agencies or even the DME companies have the opportunity to have access to the full chart for about 3 months after a patient's discharged. And so that gives them opportunity to look at other information like imaging procedures and lab work they may have not gotten from the initial documentation that we sent over. And so this has helped from the feedback, because we started this with our skilled nursing facilities first in October, and we had a few lessons learned through that. And so the lessons learned was that we wanted to make sure they understood how to utilize the tool. And then second, understanding from the hospital perspective, the time frame it takes to receive those referrals or acceptances from those facilities, and then teaching all the staff within that Epic system. So we just actually just embedded all of that into our system so they have full access to the chart.
We've had a software program we've used for about 12 years through all scripts that we've used for referrals to all of our agencies, including our own home care and home care agencies. Again, you know, as you mentioned, technology isn't always the answer, because I remember when we initiated that, everyone was like, no, we want to talk to the facilities. But no one liked standing by the fax machine, faxing millions of, I'm sure some young people here don't even know what a fax machine is. But at any rate, it became so efficient that we missed really important information sending on behalf of the patient. And remembering that as care managers, at whatever level we are the patient's biggest advocates. So we can't just abdicate to technology, although it is a wonderful tool and helps us serve many, many more patients. So we embrace it. We've, you know, and I personally am glad for this, we have individuals on our teams who are so good at it. So we allow, I mean, they're officially the good people for technology, so they manage a lot of troubleshoot for us and help us with it. And if there are, you know, vendors that might have a better idea, they're the ones that vet it for us and then help us train our staff. So I just always feel like we cannot lose sight that we are serving people. And I'm so happy to hear this over and over again at this conference, because I think we became too dependent on technology and missed the human element. whereas before we could only serve a small group of people because we're just trying to do it by phone and fax. So there definitely needs to be a happy medium.
We also leverage Epicare Link, and we implemented Epicare Link probably about a couple years ago for our preferred partners. They're actually required to use Epicare Link. That gives them full access to the chart, as you indicated, which was really significant for them, and it really reduced the kind of, like you said, the faxing and things of that nature, or can I get the most updated labs? I mean, they can go in and get that information themselves, and we really standardized what kind of key clinical elements that they needed across all of our home health and our SNFs as well. I think the biggest piece that the Epicare Link did provide for us was the opportunity for the SNFs and home health to communicate back to providers, looking at compliance, particularly for home health. If the patient had follow-up appointments, did they actually keep their follow-up appointment and things of that nature? So that was really, really helpful to get that real-time communication and that feedback. They could send pictures and things of that nature. So try to avoid that visit to the ER if at all possible, updated orders, things of that nature. One other piece of technology that we also use is Cypher Health to do our post-discharge calls, which has proven to be really, really helpful. We found that there were so many people that were doing post-discharge calls. They were not standardized. Nursing was doing, the care management was doing, population health was doing, all calling the same patients, all asking some flavor of the same type of question. So we actually implemented our post-discharge calls. But what's interesting and what's helpful with the technology is particularly for our patients who go home, because obviously we don't do calls for patients that are in a post-acute facility. The information that comes through that call, if something is escalated to one of our team members that triages the call, that information also goes to our home health agency. So for example, if patients identified on the call that they were confused about medication, that prompts a call from our team in the hospital. They may be able to triage or be able to explain the medication, but then that information also feeds to our home health agency, and then they can reinforce what was taught or what was discussed on the call as well. And so it's just really around connecting the dots. I agree, technology cannot solve the issue, but I think what is key about technology is that we're smart in our selection of technology, and it improves the communication. Often when we come to these conferences, we're all doing some of the same things, embedded providers in facilities and warm handoffs and things of that nature. But I think where often where the opportunity is just gaps in communication, and so where technology can help is to shore up those gaps and making sure that we are all sort of on the same page and it's not fragmented and siloed. And so we're really strategic about the use of technology and where we want to embed it. Technology for technology's sake is not going to solve the problem.
I would say at Duke we use the Epic Care Link as well, and that recently we have discovered what was being sent to the facilities wasn't always what we thought was being sent to the facilities. So that's a performance improvement initiative we're doing now, is really working and collaborating with, which has helped with this HOPE Collaborative, reach out to the facilities and all of us, sit at the same table to say, what are you getting? What do we need to have on what's coming to you? So, but that has been helpful in communicating. But I do agree, you still have to have that face-to-face connection.
We even went back to an old checklist for when we sent the patient from the hospital to a skilled acute or LTAC. We have an envelope with paper, not a lot, but some pertinent paper, including the MARS, in the envelope, and a checklist to say what we have sent electronically and what's in the envelope. So again, kind of back to the future, we found this was a way to across all our hospitals to have a uniform method, not technological method, and so all of our receiving facilities would know what to expect from our hospitals.
Thanks.
We took a little different position in that, so I will admit I'm one that tries to eliminate the papers as much as possible. Not nurse, and so we tried to be a little proactive in creating that checklist up front and in partnership with our providers. So it's pretty standardized. So really and truly, like there's a packet that just kind of gets created within the unit. But again, the weekly care conferences really allows for us to, if something is missing or something that they needed, or maybe there's something that, you know, is special about this patient, some information that they needed, that's an opportunity for us to discuss that proactively, so you're not waiting weeks into the patient's stay before you recognize that they don't have that information. So I do think that communication, live communication, those care conference weekly really has been very beneficial for us.
Thank you. So as a quick time check, we have about 10 minutes left, which means probably 2 to 3 questions. Anyone in the audience? There's either a microphone there, or if you have a really loud projecting voice. Okay.
So this is really interesting that you're organizing care. One of the failure points is obviously right discharge and handoff. So some component of that. But then the whole thing about complex caring for patients beyond the hospital wall. Once you kind of get out of that window that you're looking at, this 30-year readmission window or mitigating immediate complexity, how is your strategy tying in with the broader ambulatory care strategy to manage those conditions over a longer period of time? Because that's really where the opportunity is. Right? So I'm wondering how you're addressing that and what challenges we have in mind.
So our population health partners and care team is part of our care conferences. So there is a warm handoff with them, and they're intricately involved in all of our processes, whether it's the weekly care conference or the monthly care conference. So there is sort of line of sight for them once the patient is discharged from any of our post-acute partners. So that's one. But for our most complex patients, those who maybe are frequent utilizers and things of that nature, we do have a process where we have complex care plans that are created for those more complex patients, and those care plans are multidisciplinary created care plans that include providers, primary care providers, specialists, hospitalists, so on and so forth, that create that. I have a physician one of our unit medical directors that really kind of spearheads that effort to create those care plans and reach out to the other providers. So if a patient does appear, whether it's an acute care facility or in one of our specialty or primary care offices, there's a BPA that automatically fires with that care plan, so they can see what is the plan for that patient, any complications for that patient, and we constantly monitor and we update those care plans, and they can add input into those care plans as well. So that's one way we're able to continually monitor our most complex patients and make sure that they are, that we kind of have sort of overview of what's happening with the patient as well. In our population health department, those patients are followed either telephonically or in person, depending on the patient and the complexity of that patient as well. And we do have a comprehensive care management plan that all different care managers can provide input. So if you look up a patient, you see that plan, it's right there on the top, there's a complex care plan. You can kind of see sort of the interactions that everyone has had with that patient and how they've touched that patient.
And we also have a transitional care team, so I won't go into the complexities of how that team works, but we, for our ACO, we have a team, and for some of our special single plan insurance companies, we have a team. And then for our patients that aren't necessarily aligned with the clinic, we have a hub that files them, and make sure that they are handed off to the next care provider, whether they be in Tennessee or Abu Dhabi. We make that connection so that they're connected to the primary care provider. We also use in Epic a tool to send the discharge summary to the next care provider.
So for WellStar, we actually have over 200 physician providers in the state of Georgia. So that's a good thing, and they all actually document in Epic. So we're able to actually see the documentation, the appointments, and just collaborate within the actual system. Secondly, we have our population health case care coordinators who are embedded in our ED, who's embedded in care coordination within the hospital. And so we actually, those patients specifically are identified in bold and also in orange on our header in Epic, so we'll know that this patient is transitioning to that population health patients, or they're transitioning to one of our WellStar providers. Another thing is that we do have we call it GME clinic, which is a clinic for patients who don't have insurance, who are indigent, and we have quite a bit of those, and we send those patients over there to make sure they are transitioning and following up with appointments, especially with those complex chronic diseases. We make sure they go over there. We, as far as walk them over there. From Kennestone is actually across the street.
So literally take them over.
Yeah,
Okay.
and the reason being is because we find that there's a no-show type of, a high no-show percentage. And so just to make sure that they are following up, we do that extra step for them just to get them over there.
Yeah, and I would say we have population health, and that's part of, especially working with the homeless transitions group. The other complex case manager and I, we hold on to them until we know somebody else has them in the community, because if we don't, we know we're just going to see them right back. So we're kind of open-ended until we can really connect them with population health, or the homeless transitions group takes them, and they've done a really good job about housing them, permanent housing. They know where the vouchers are, so really making sure they're connected to somebody that's going to follow them on a more long-term basis, I think, has been helpful.
Thanks. So we have 3 minutes. Oh boy, spirit of fairness here. I saw the hand in the back left first. Or are you just yawning? Okay, all right. All right, you can go ahead.
Well, this might not be a good question to ask in 3 minutes, but I'm just in the spirit of complex patients, not only medically complex, but socially complex. Can you talk a little bit about if you have, and I hate to say it this way, but more of like an aggressive strategy with sort of getting guardianship and conservatorship? Because I think a lot of these situations, medical complexity is one thing, but not being able to get them resources so that there's sort of an end game, right? I mean, you want these people to be able to return to somewhere, to live somewhere, to have a payer source, and part of that without engaged family becomes a huge barrier.
Yeah, and that I'll speak to that. That's part of what falls under our umbrella as complex case managers. We have the guardianship piece. So whenever people identify, or the physicians identify, this patient needs a guardian, myself or Gay go and meet with the patient, and then we figure out, is there family? We have a good connection with Adult Protective Services in the different counties to help us search for families. And if not, then we'll work with them to pursue guardianship. And it's a long process, but like he was saying, it's a more long-term solution, because otherwise those patients are going to keep coming back to your hospital. So we own that piece of it, and we help to get guardianship so that we can get them all those resources. And we're also working with the hospital sponsorship, so we can also sponsor these patients at a facility while we continue to follow them and work on that process.
We also have responsibility for guardianship as well. I will say that we try our best not to take guardianship. And there was a time when I would say some years back when it seemed like everyone was, we were taking guardianship. So we are really careful. We spend an exorbitant amount of time looking for family, making those connections, looking for other healthcare surrogates, friends or whomever can help support before we take guardianship. And we have actually reduced the number of patients pretty significantly that we have guardianship over. I think the biggest challenge with us is really our undocumented population. That really has been the challenge. And there are no resources. In Illinois, we do have Medicaid expansion, so many of our patients do have some funding source, but the undocumented is a whole different area of opportunity. So really, in many of those cases, instead of taking guardianship, what we try to do is repatriate them as much as possible, but it continues to be a challenge. I know that everyone probably is facing.